So today's talk is a melanoma education and treatment. And as you probably heard, there has been a lot of changes over the last 5 to 10 years in melanoma world. So in the past, my talk has been really easy because nothing much going on, treatment doesn't work. But now we have great treatment options for the last 5 to 10 years. So certainly my slides have become more busy and more complicated, so I hope you understand. So let's go with the melanoma incidence and epidemiology. First, skin cancer is very common. So about 3.5 million cancer diagnoses within 2 million people a year. Melanoma is the most dangerous skin cancer form. But fortunately, it's a very small portion of skin cancer is melanoma. So less than 5% of cases are melanoma, but it accounts for more than 75% of the skin cancer death in the United States. And in 2020, we estimate about 100,000 patients are diagnosed with melanoma, and more than 6,800 people are expected to die from this disease. So this could be quite a bad disease. If you look at new cases, melanoma is the 5th most common cancers in the United States among men, and 6th most common cancers among women. So this is an important disease to treat. As you heard in the media or news, many of the cancer incidence has been decreasing over the last decade. Prostate cancer, lung cancer has been decreasing, but melanoma is one of the few exceptions. So for the last almost 30, 40 years, the incidence has been increasing over time among men and women. So it has become more of a bigger problem. UV light and sunlight are the most important environmental factors for developing melanomas. Even though we all know we have to watch for suns, not getting melanoma, but there's some less common types of melanoma, such as acral melanoma, mucosal melanoma, ocular melanoma. These are not typical skin melanoma we talk about. Acral melanoma is the one that happens in the palm of the hand, soles of the feet, fingernails, toenails. Mucosal melanoma are the ones happens in the mucosal surface, such as in the rectum, inside the vagina, inside the nasal sinus. And ocular melanoma is in the eye layer called choroidal layer in the eye. So these are less likely to relate to the UV light because, well, I mean, how many people suntan their rectums or in the sinus? So we know these can be probably not related to UV light. And listed here are the risk factors for developing melanoma. So sun exposure, once again, and heavy exposure during childhood, and multiple sunburns are the risk factors for developing melanoma. And usually Caucasian patients, people tend to have more risk of developing melanoma, especially Irish or Eastern European ancestry, fair skin complexions that sunburn easy, a blonde or red hair, blue or green eye colors. These are the people who may develop melanoma more than other ethnic groups. Presence of multiple moles and freckles. So more number of moles and freckles tend to increase risk of developing melanoma. And presence of dysplastic nevi, which means atypical mole upon biopsy, is also a risk factor. And family history of melanoma and personal history, previous history of melanoma makes you a higher risk for developing melanoma in the future as well. These are the warning signs of the lesions. We call this ABCDEs of diagnosis of melanoma. A stands for asymmetry. So one half of the lesion doesn't look the same as the other. B stands for borders. Also, some people call this the bleeding as well. So the border should be round and kind of even if it's benign moles. But melanoma tend to have more irregular borders and scalloped notched borders. Also, if the lesion bleed, this is kind of suspicious because benign moles shouldn't bleed spontaneously. C stands for colors, and doesn't mean that's black as the color, but it especially has different shades of colors within the one lesion, like this one here, the redness in the corner, the blackness. This different variation within the lesion is a danger sign. Also, the diameter, the size of the skin lesion itself, can sometimes predict this could be a melanoma. But most important, in my view, is E for evolution. So any changes in asymmetry, size, and colors you have to watch for. Example of melanoma. So it's irregular borders, not round, elevated. Another lesion with irregular borders. And look at the striking the colors. You got some little no colors, skin color here, black color in the middle, and redness. So all different variation within one lesion. That's dangerous sign. This is like, looks like blood blister. People think, oh, it's nothing, just a blister, no big deal. But if it grows, becomes more elevated, you have to biopsy. And the worst case is that this so-called nodular melanoma without colors, looks like regular skin, and even dermatologists can miss it. They think this is just a regular cyst or in the blisters, no big deal, but this can be melanoma. Irregular borders, asymmetry, and irregular borders here once again. And different colors, white in the middle, the black outside. And this is example of the acral melanoma that happens in the, occurs in the palm of the hand. So different, the shapes and size of melanoma you can see here. So what do we do? Ways to lower risk of developing melanoma is the main thing is reduce the intense UV light and sunlight exposures. Very important, both UVA and UVB light rays has to be the reduced. UVB tend to be more intense, a shorter wavelength, so it can cause more sunburns. But you cannot ignore UVA light because more exposure of UV light can also increase risk for developing skin cancer. So recommendation I would give is, if possible, if you go outside, if you're trying to avoid between 10 a.m. to 4 p.m. if possible. Also, indoor tanning beds and sun lamps is another source of UV light. So I don't recommend using indoor tanning beds or sun lamps. In fact, in many states now, if you're a minor, you cannot even go to the indoor tanning bed. It's a law, against the law, to protect minors or young people from developing melanoma in the future. Obviously, staying in the shade. If you have to go out between the intense sun hours, then try to stay in the shade. And put on clothing, pants, shirts, protect your skin. Sunglasses, so it can protect your eyes, around eyelid, and other places in the face as well. Sunscreen lotion is very important, but sunscreen lotion doesn't protect 100%. So even with the sunscreen lotion, we still recommend, put some clothing on, stay under the shade if possible. Recommendation is sun protection factors over 30 or above to use for the sunscreen lotion. Higher number doesn't necessarily mean that it's much better than 30. So if you use 50 of SPF, it probably protects 1% more than what 30 would do. Even SPF 100 can protect small increase and incremental of reducing UV light, but not too much better. So, and it's 30 or above will be good. Cloudy days doesn't mean that there's no UV light. You still have to watch. And if you go snow skiing or the water sports, don't ignore the sun reflection from the snow, sand, or water. As we said before, not all melanomas are caused by UV light and sunlight in case of the eye melanoma or rectal melanoma, for example. And very important, you be familiar with your skin. So regular skin check maybe once a month, especially if you have a lot of moles and freckles. If you have family history or other risk factors, then you want to see a dermatologist regularly as well. Talking about staging of melanoma, there are T and M staging, typical for many cancers. The T staging means primary melanoma tumor itself. The thickness of the tumor is important. And as you can see, status of ulceration of the melanoma is important. What does ulceration mean? Is that it's not just a look from outside, but if you do a biopsy of the lesion, the melanoma is exposed to the air. That's ulceration. Because most melanoma start underneath and it's covered by epidermis layer of skin. So most early stage, less dangerous melanoma is not exposed to the air. But once again, if exposed to the air, that means ulceration, diagnosed on histology or under the microscope only. So melanoma thickness and ulceration status in the melanoma that determines the prognosis and staging, not necessarily the size of the melanoma lesions. Earlier, we said diameter or the size of the lesions can be a warning sign this could be melanoma, but once diagnosed, the depth into the skin layer, perpendicular depth, is more prognostic than size of the lesion from visual vision. N stage is for lymph node status. Basically what it means, if you have more number of lymph nodes involved and bulkiness is larger to the metastasis in the lymph node, more worse prognosis, as common sense would dictate. And M stage is for distant metastasis. It can go to the distant skin area or lungs, liver, bones, or brain. So melanoma can go anywhere. So distant organ metastasis has poor prognosis in general. So this is a breakdown of staging system. It's very complicated. It becomes more complicated every 10 years when they update. But basically stage 1 and 2 means they are primary site lesion only without metastasis to any place else. Stage 3 means from the primary site, it spreads through lymphatic channels to lymph node involvement. So so-called regional metastasis, regional the lymph node involvement. Sorry about the this typo here. And the last one is metastasis. In fact, stage 4 is, sorry again, the misspell. This is for the distant metastasis, the spread to the different organs. If you're dealing with stage 1 disease, prognosis is not bad. Most patients, 10-year survival is 95% or above. Stage 2 disease, it varies quite a bit, from down to 75% up to 88%, depending on the thickness of the melanoma and ulceration status. 3 has, once again, big variation in the prognosis. If they only have one lymph node, microscopic with thin melanoma, 10-year survival can be as good as 88%. But if patient has more than 4 lymph nodes positive metastasis, then the 10-year survival drops down to 24%. So it's very important to accurately diagnose what stage patient is. Is it 3A, 3B, 3C, or 3D? And oncologists can tell you about what stage patient has and make plans what to do about it. So treatment for the so-called localized disease, if you're dealing with stage 1, 2, or 3 disease, the first thing, the best option is a good surgery. So-called margin negative surgical excision is the best chance of obtaining cure. Sentinel lymph node biopsy can be considered in some cases. And we can talk about what that means a little later slides. And this lymph node biopsy can detect microscopic spread of melanoma into the lymph node. Size of the surgery, depending on the thickness of melanoma, it can be as small as 0.5 centimeters. But if a patient has melanoma more than 2 millimeters thick into the skin layer, then it should be 2 centimeters of the in all sides. So the radius should be, the diameter of the skin should be 2 times of 2 centimeters, because 2 centimeter radius. So it should be at least 4 centimeters. But if you do a round surgery, then it'll be hard to close it. So many times you do elliptical, the shape of the surgery, making long scar can be a result of the even thin melanoma in general. Surgery is very important. We briefly talked about sentinel lymph node biopsy. The concept is this. If this melanoma spreads through the lymphatic channel to the lymph nodes, for example, melanoma is in the hand, it can spread to the under the arm axillary lymph node. Then, well, how do you know which one has lymph node, and how do you know if any lymph node is involved with the melanoma? So in the past, the surgeons used to do a dissection on everybody, take the whole lymph nodes out in the region. But unfortunately, many people didn't have metastasis and end up with complications such as lymphedema, swelling, pain, and swelling and everything. So the concept is, why don't we inject some blue dye and around the melanoma site and then see how this blue dye spreads and then end up in a certain lymph node. And this lymph node here in the blue doesn't mean this has melanoma, but this is likely first lymph node that melanoma can involve because the pattern of the spread goes to this lymph node. So if you go under the surgery, you can see the blue lymph node with a blue dye. Take that out. If the lymph node is negative, then chances are other lymph nodes is probably negative. So we leave it alone. If lymph node is positive, then there's chance they may have other lymph nodes can be involved with the melanoma. Then we can consider lymph node dissection in some cases. So 5 years ago, 3 years ago, the standard was if this lymph node is positive, then everybody has to go through lymph node dissection to remove it. But that practice was questioned for a while. And there is a clinical study to show, do we really need lymph node dissection on everybody if the lymph node is positive by sentinel lymph node? In the European study, German study, after lymph node dissection of stage 3 patients, half of the patients just observed without further surgery, and the other half had the lymph node dissection. At the end, distant metastasis-free survival, recurrence-free survival, and overall survival, there's no difference between doing nothing versus even aggressive surgery, meaning having big surgery to detect other lymph nodes didn't really end up in reduction of recurrence or survival or cure rate. Similar study in the United States showed the same result. At the end, survival, no difference between surgery versus not. So to talk about treatment of these patients, we consider the sentinel lymph node biopsy if patient has somewhat higher risk of recurrence or lymph node metastasis. So many surgeons would consider 0.8 millimeter as the cutoff point to consider sentinel lymph node biopsy, and presence of ulceration, mitotic figure, which means how many cells are dividing at the time of the surgery biopsy under the microscope. If cells are actively dividing, then patient may need lymph node biopsy. Or other signs of the possible high risk, then we consider sentinel lymph node biopsy. And if patient has the palpable, patient comes with a big mass under the arms, or CAT scans, PET scan shows big mass in the lymph node, then patient will need dissection. That's the standard. But as we discussed, if patient has no symptoms, PET scan doesn't pick up, CAT scan doesn't pick up, then if diagnosed by sentinel lymph node, the microscopic disease, then many patients may not need lymph node dissection. That's a new standard at this point. What can we do if patient diagnosed with a stage 3 melanoma with high risk of recurrence? The treatment to prevent recurrence is called adjuvant therapy in cancer. So in the old days, high-dose interferon alpha treatment was tried. In fact, it was approved in 1995 for use to prevent melanoma. Despite initial success of this one clinical trial, the follow-up studies, multiple studies, and a long-term follow-up didn't really show improvement in cure rate or survival rate. Yet, the high-dose interferon is very toxic, and 1 year treatment And even young people can have significant fatigue and flu-like symptoms. And even if the drug was approved, even back then, many doctors may not recommend this treatment at the time. Let's talk about new immune therapy ways to prevent recurrence. It's called checkpoint inhibitor. This is the concept. This is the break in immune systems, in immune cells. Can you release the break in the immune cells to make them stronger so the immune cells can fight tumor cells yourself? One of the break proteins that interfere with the T cell is called CTLA-4 proteins, which reside within the T cell immune cells in your body. Its function is trying to suppress T cell activation so your immune cell doesn't go crazy and causing all this autoimmune disease. But in cancer patients, we like to get your T cells strong, immune cells strong, so it can fight tumor cells and kill tumor cells. And T cell, they're the ones who can actually kill tumor cells in your body immune system. So can we block the CTLA-4, the break of the immune T cells, using the antibody, the blocking this CTLA-4 proteins to release the break, and T cell can go strong? That's the concept. In fact, one of the medication of the anti-CTLA-4 antibody is called ipilimumab. There's a large randomized international study when patient had surgery with a first stage 3 melanoma, and after surgery, they were randomized to ipilimumab treatment for 3 years versus placebo, and see what happened to those patients. Primary endpoint, primary goal is to prevent recurrence of melanoma. What it showed is recurrence-free survival, distant metastasis-free survival, overall survival. There's improvement with ipilimumab treatment versus placebo in all groups. In other words, ipilimumab treatment that delayed recurrence, reduced the chance of recurrence, reduced the chance of distant metastasis. Also, patients live longer, more people alive in each year. So at 7-year period, almost absolute 10% improvement in survival at the time. So for that reason, in 2015, FDA approved high-dose ipilimumab treatment as a result of this study. But the problem is that ipilimumab can be quite toxic. The immune-related toxicity can be significant. Next proteins, next development is called PD-1. PD-1 is another protein, also a checkpoint inhibitor class. Its function is once again trying to improve T cell activations. So PD-1 is similar to CTLA-4, slight different binding characteristics. The concept for treatment, let's block this PD-1 using antibody therapy. So block this bonding, so basically make this PD-1 useless. And that means you're releasing the brake on T cells, and T cell becomes stronger. Now we can attack tumor cells better. Examples of PD-1 treatment is called nivolumab or pembrolizumab. They are basically the same class of medication made by 2 different companies. So I consider them as basically the same medicine, like Motrin versus Advil. They're both ibuprofen. I cannot say one's better than the other. Of course, you have to prove in a clinical study. So same design, stage 3 patients after lymph node dissection, patient randomized to pembrolizumab for 1 year versus placebo. And see what happens to this patient and look at recurrence-free survival. And at the time, the placebo control was ethical because, well, there's no great treatment at the point, so many patients had just observed anyway. So it was placebo as the ethical control group. After 3-year follow-up, a significant improvement in patients' recurrence-free time, meaning less risk of a recurrence at 3-year period. So 63% of the patient in the treatment group was alive without recurrence versus only 44% in the placebo group was free without recurrence. Similar, nivolumab was tried this time against then standard ipilimumab treatment. So thus, PD-1 treatment is better than CTLA-4 treatment, even though their function is similar to activate T cells. Once again, stage 3 disease patients, and also this study allowed stage 4 patient with surgical resection of the isolated lung or liver metastasis, randomized nivolumab versus ipilimumab. Big study, almost 1,000 people. And once again, as expected, PD-1 treatment was superior to ipilimumab treatment. So at 3-year period, 58% was free of recurrence with the PD-1 nivolumab treatment versus only 45% of the ipilimumab group. Well, success. So both medications approved. Pembrolizumab, nivolumab approved by FDA. So it's available for patients with stage 3 disease after surgery. Another class of medications called target therapy, so-called precision medicine. There's a lot of proteins, genes going haywire and going crazy in tumor cells. But there's some pattern emerge in melanoma. About half of the melanoma patients has mutation in the gene called BRAF gene mutations. What it does, basically think of it as the green line as the cell membrane. So under the green membrane, green light is the cell, inside the cell, melanoma. This is outside. Having BRAF mutation, it activates automatically the chain reactions of proteins causing tumor cell survival, tumor growth, and invasion metastasis. So having this mutation, abnormal mutations, can be a bad thing for patients. This happens about half of the patient with melanoma. So concept, let's block this bad mutation. Let's inhibit this mutation of BRAF. Also inhibit the pathway called MAP pathways. If you block the pathway, then maybe we can slow down the tumor growth. We can stop, and also it can even kill tumor cells, and people can live longer. In phase 3 clinical study of this approach, BRAF plus MEK target therapy approach versus placebo in patients with the BRAF mutations only. Once again, this is target therapy against this molecule. So if you don't have this molecule, then this treatment will be nothing. It'll be a waste of time. It's a waste of resource. So you have to have this mutation to qualify for this clinical study. And the result was as good as we initially expected. Patient getting target therapy for BRAF mutation had significantly improved recurrence-free time or free of disease at 5-year period versus placebo group. So now we have all these options. We talked about interferon, ipilimumab, nivolumab, pembrolizumab, and target therapy called dabrafenib, trametinib. These are all available, but now with this better information and better efficacy, the first option would be nivolumab or pembrolizumab or dabrafenib, trametinib. Less likely to recommend interferon or ipilimumab. In fact, the so-called NCCN guidelines, the expert panel, don't recommend these 3 drugs anymore as a first-line treatment. Between the 3 groups, controversy, which one is the best? At this point, still controversy. Maybe time will tell which one may be the winner. Maybe it's all good, maybe in the future. Okay, moving on to the treatment for metastatic melanoma. So these are the patients we can resect by surgery, or they have metastatic disease, so we have to use the drugs to treat melanoma. Before 2009, survival of patients with a stage 4 melanoma is very poor. So at 5-year period, only 10% of the patients are alive, meaning 90% of the patients die of disease within 5 years. So the melanoma used to be very bad as pancreatic cancer or the lung cancer. 3 major treatment options: chemotherapy, immunotherapy, target therapy. Once again, so-called molecular target therapy. Chemotherapy is the least effective, and it could be toxic. So we don't use chemotherapy unless We are talking about last resort or desperate situation. Immunotherapy, target therapy is the one we usually recommend in 2020. Before 2011, only 2 medicines FDA approved, dacarbazine chemotherapy, interleukin-2 old immune therapy, but these never showed survival improvement or improvement in cure rate overall, and they could be toxic and not very effective. The median survival, the average survival of the patients, only about 6-9 months at the time. Once again, let's talk about target therapy once again. We talked about BRAF mutation earlier to prevent recurrence. The concept can be useful in metastatic setting as well. So 3 drugs called vemurafenib, dabrafenib, and corafenib are the BRAF inhibitor specifically target this protein, not bothering other proteins. So one of these medications, all 3 medications can block this BRAF mutations, blocking the chain reactions, causing tumor cells to die. In fact, in clinical study, vemurafenib compared to all chemotherapy called dabrafenib showed significant improvement in tumor control and survival of the patient, and significant tumor shrinkage, almost 50% with the BRAF target therapy versus 5% of the chemotherapy. No brainer. This drug was approved in 2011 for patients with the BRAF mutant melanoma. Once again, only about 50% of melanoma has this BRAF mutation. Similarly, dabrafenib was approved because of the improvement compared to chemotherapy. The problem, if you use single agent drug, look at the significant improvement. After 2 weeks of treatment, the liver lesion, the dark activity in the liver pretty much went away, and patient feeling great. Some patient can tell me after even 3 days of treatment, tumor starts shrinking, they can breathe better, they have more energy. But the problem is many patients within a year, many times 6-7 months, tumor comes back and becomes resistant to this treatment. So concept is, well, how do you know? What do we do to make things better? All the research over the last decade trying to find out what's the reason the resistance happens on this treatment. Majority of patients, even though this pathway was blocked by these BRAF inhibitors, somehow cancer finds a way to reactivate these pathways. So they can use other proteins to activate these pathways to drive cells to grow and metastasis. So concept is, can we block the downstream pathways in addition to the BRAF inhibitors? So double blockage to completely lock down on these pathways. Maybe they could be better. And as the research have predicted, combination of this BRAF plus MEK treatment was better than single agent in all 3 different clinical trials by 3 different companies. So combinations of dabrafenib plus trametinib, vemurafenib plus cobimetinib, and corafenib plus binimetinib showed these combinations are better than single agent BRAF inhibitors. So in 2020, the current standard, if we use target therapy for BRAF mutation, has to be a combination, not single agent drugs. And at a 5-year follow-up of this, the target therapy, at 5-year period, nearly 1/3 of the patients are still alive with this target therapy. That compared to only 10%, 10 years before, we're talking about 3 times improvement in 5-year survival rate. Next chapter is, well, what else beyond BRAF? We talked about half of the melanomas have BRAF mutation, the other half will not. But different melanomas has different mutations. For example, acral melanoma that occurs in the bottom of the feet, fingernails, they tend to have some KIT mutation along with the BRAF. Mucosal melanoma in the mouth, rectum, and in the sinus tend to have more KIT mutations. So different mutation, different gene is used. Eye melanoma, this doesn't use BRAF or KIT mutations, but then they use different protein called GNAQ or GNA11 mutations, which is totally different proteins for which there's no great treatment that we have at this point. So these research will hopefully lead to the right treatment for right mutations so it can improve survival and cure rate in the future. Going back on immune therapy for metastasis, we talked about CTLA-4 antibody earlier. Same concept used in the different setting, metastatic setting. And in the clinical study of trying to use ipilimumab, the CTLA-4 antibody, compared to the comparison group of vaccine at the time, showed survival of the patients was improved with ipilimumab, and tumor control before tumor gets worse was better with ipilimumab versus control group. So for that reason, this was actually first ever showing the survival improvement of any drugs in melanoma in 2011. So for the result, FDA approved drug called ipilimumab. PD-1, we talked about PD-1 earlier in the stage 3 adjuvant setting. And same result came in metastatic stage 4 disease patients to shrink tumors and live long. When nivolumab was compared to chemotherapy, which was de facto standard back then, 10 years ago, nivolumab has significant improvement in survival. So higher curve means better survival. And the pembrolizumab, another PD-1 treatment versus CTLA-4, the ipilimumab, also showed improvement of pembrolizumab over ipilimumab. So even in metastatic setting, PD-1 treatment was better than CTLA-4 antibody treatment, just like stage 3 patients. 5-year survival with the pembrolizumab, 43% of the patients still alive at 5 years. Nivolumab, 44%. So if you compare pembrolizumab versus nivolumab, they're basically same class, same medication. 5-year survival is almost exactly same from 2 different companies, 2 different clinical trials. Then, one step further, can we make even better? Can we even combine PD-1 plus CTLA-4 antibody together? Would it be better to improve T-cell immune therapy functions? And that trial was done in the protocol called the Checkmate 067 trial. The yellow line is a combination of the PD-1 plus ipilimumab, the nivolumab plus ipilimumab. Blue line is nivolumab, and green line is ipilimumab. Once again, nivolumab was better than ipilimumab. Combination in the yellow curve was better than ipilimumab. If you look at purely number-wise, median PFS, meaning how long does it take before tumor gets worse in half of the patients, so 11.5 months with a combination versus 6.9 months of the nivolumab alone versus 2.9 of the ipi. So it appears that combination has more effectiveness, and in the response rate, tumor shrinkage happens about 60% with the nivo-ipi, 43% with single agent nivo, 19% with ipi. So it appears that combination appears to be better. But something that I have to tell you, this clinical study was designed to compare combination versus ipilimumab and nivolumab versus ipilimumab, but not between those 2 curves. So even though there's tendency of improvement by combination, it's not confirmed. To answer the question, we need another large prospective clinical studies head-to-head between those 2 alone to see really how much improvement we're talking about with this combination versus single agent. With the combination, at 5-year period, 52%, more than half of the patients are alive. Compared to, remember, 10% from 10 years ago. So we have seen improvement in 5-year survival or beyond with the recent medications. Something about the immune therapy, this can have significant side effect, immune side effect, because we are basically activating T cells, immune cells, it can sometimes backfire. It can have collateral damage. So your immune cells can sometimes irritate your own normal cells. So-called autoimmune disease, it mimics that. So you can have the colitis that mimics Crohn's disease. You can have irritation in the skin rash, called dermatitis, that resembles lupus or psoriasis. It can cause hepatitis with the liver stress, lung stress, and the hormone level can drop, like thyroid level can drop. Steroid production can drop. So these can be the side effect. Most side effect of the immune therapy is transient. So once treatment is done, then colitis goes away, diarrhea goes away, skin rash goes away, liver becomes fine, liver, lungs recovers. But some toxicity can be more long-term or possibly permanent. Very small chance if patient gets diabetes, let's say 1% or less chance of getting diabetes from the treatment, this may be a long-term problem, even after stopping treatment. Or endocrinopathy, which means hormone changes, like low thyroid, low steroid level. You may need supplement for a long time to come. If patient has really significant side effect, then we have to use steroid, high-dose steroid, to lessen the immune functions, calm down the immune system so we can improve it. So steroid is an antidote for the side effect of the immune disease, works quite well. But then we don't want to block down immune systems too much. So we have to taper off and then we have to stop once side effect improves. When you see a patient with immune therapy, if patient has mild side effect, they can still do a carry-on life, the usual life, travel, work, then we leave them alone. But if any side effect becomes more life-threatening or changing your lifestyle, you cannot go out and meet people, you cannot work, you have the home all the time, then maybe we may have to hold the treatment and treat the side effect of the immune therapy with a steroid. In 2018, two physicians or researchers received Nobel Prize in medicine. Their work is basically just this, checkpoint blockade. This class was developed by these two men, Dr. Jim Allison. In fact, he developed this CTLA-4 in the Bay Area when he was at UC Berkeley, and also Dr. Honjo in Japan. Dr. Allison was the first one to get the concept of this break on the immune systems and make first checkpoint inhibitor called CTLA-4 antibody. They have shown improvement in survival in melanoma. Dr. Honjo separately was working on PD-1 molecules and developed PD-1 antibody. And now both medications, we can definitely see the positive impact on melanoma patients. So we certainly benefit from their work and their colleagues and numerous researchers around the world in this field. Once again, 5-year survival. Before 2010, very poor, 10% or less. Now, depending on which trial you see, it could be anywhere between 35% up to 52%. And once again, I cannot tell you one is definitely better than the other. If you repeat study again, maybe the order may be reversed, who knows? But the conclusion of this slide is that these new medications definitely has improved survival of the patients and probably cure rate as well. We have a number of new options as we discussed, and now we talk about improved 5-year survival. Before 2011, for decades, we only had 2 medications which didn't really improve the survival rate. But since 2011, we have 10 new medications FDA approved for these, the effect and improving survival. So this is a summary slide. Stage 1 or 2, localized disease hasn't spread anywhere. Then good surgery, why local excision is important. And if patients tend to have a high risk, then we do a sentinel lymph node biopsy to elicit or find out about the metastasis in the lymph node. After that, after surgery, there's no treatment necessary. But if patients tend to have a high risk, like 2B or 2C disease, then we highly recommend clinical trial participation in those patients. Stage 3 disease patient. These are the ones regional metastasis spread to the lymph nodes, and they'll need lymph node surgery, either dissection or just lymph node biopsy. And afterwards, we have a number of options, such as PD-1 treatment, like nivolumab, pembrolizumab, or target therapy if BRAF mutation, dabrafenib trametinib for 1 year. Or once again, if you can have clinical trial based on these medications, hopefully make it better than current standard, we certainly recommend clinical trial as a first choice. Ipilimumab, interferons are less out of favor because of toxicity and less effectiveness. And some patients, observation may be reasonable. Stage 4 disease, mostly systemic therapy, either immune therapy or target therapy if patient has BRAF mutation. Chemotherapy and high-dose IL-2, old medicine, we rarely use this anymore in 2020, but we have a number of options of this new immune therapy, combination, target therapy. Once again, if we can have promising new drugs based on these medications, adding to these medications, I would certainly recommend clinical trial participation in the patients. So with that, I will stop my talk here. I'll be happy to take any questions at this time. How might a person's life hold? And for how long if they are diagnosed with skin cancer from diagnosis through treatment? Okay, so the answer to that would be depending on what stage we are talking about here. So stage 1 disease tend to have a good prognosis. Once again, 10-year survival is more than 95%. Stage 2 disease can be anywhere between like 75% up to 88%. Stage 3 disease, once again, is a big variation. Whether 3A disease versus 3D disease, it could be as low as 24% 10-year survival, or it could be as good as 88%. So it's a big variation in stage 3 disease. Stage 4 disease, when they're diagnosed from the treatment time, used to be really short, about 9 months of survival in the past, but now median survival, average survival is more than 2 years, very close to about 3 years now. So things have changed quite a bit. So it's hard to answer the question in general, but each specific stage and patient may be different. But certainly it's better than 5-10 years ago. What is one of the most promising drugs I've seen at the moment in a clinical trial setting? There's a number of trials that are happening at this point. I cannot say it's only one that I can say it's promising. One option is a combination of the immune therapy plus target therapy. We talked about BRAF mutations, we go with target therapy or immune therapy, but then why not both? Can we do target therapy and immune therapy? So there were 2 clinical studies to answer that questions. If patient has BRAF mutation, then both groups, both studies, the design is using PD-1 treatment plus the target therapy, BRAF plus MEK treatment versus target therapy alone. So having addition of immune therapy to target therapy makes better or not. One study is still ongoing, but the second trial has already showed the result. It showed the primary goal of the prolonging the tumor controls, so delaying the tumor recurrence, was definitely superior when you do 3 drug combinations versus 2 drugs, meaning when you combine immune therapy plus the target therapy was better than target therapy alone. So that combination is being reviewed by FDA. So we'll hear maybe towards the end of the year or next year what they will say. But the downside is more toxic. So if a patient has significant side effect, is it from the immune therapy or is it from the toxicity? So depending on the degree of the benefit versus the severity of toxicity, the FDA may give us the go ahead, yes, it's approved, or maybe not. So we'll see how that combination will show. Would there be any side effects to possibly having the increased survival of T cells. If you were to turn off the CTLA-4 protein in T cells, if there would be any downside of having too many active T cells, would these cells inactive themselves after a certain time period? Okay, that's a good question. The question is basically, if you activate T cells too much, what's the downside of it? What's going to happen? Short-term and long-term. The main purpose of immune therapy, especially checkpoint treatment, is trying to turn on T cells, and that kills tumor cells. It's great. Some patients, no side effect, almost nothing, maybe mild fatigue for a day or two, for a whole year or even more, no problem. Some patients have significant diarrhea, significant skin rash, or lung problems. So everybody has different sensitivity and the reaction to treatment, because when T cell becomes really active, it can sometimes go overboard, not just killing unusual, the bad tumor cells, but it can irritate your own cells. And we cannot predict who's going to be the ones who are going to have side effect, who may not. Once T cell becomes too active, start irritating your own body, then all the side effect happens: diarrhea, colitis, diarrhea, the dermatitis, and liver problems. And usually, most times, if you leave it alone, it'll probably get better by itself. But then we don't want to leave it alone, because if somebody has really bad diarrhea, having colitis, this can cause puncture of the bowel. There has been some case of death because of toxicity from the colitis or pneumonitis, lung dysfunction. So we want to have treatment to lessen T cells artificially by giving steroid medications to lessen T cells. Even after the side effect, many patients over time, the active T cells calms down. So let's say after 2-3 years after treatment, then T cell becomes much calmer, but it turns on memory T cells. These are T cells recognize tumor antigens and tumor proteins and tumor. They become kind of dormant but present, and their function is somehow the tumor cells somehow become they recur again. They see again. They wake up, start waking up the other immune cells to attack tumor cells again. So even if T cell becomes calmer, side effect goes away, this memory T cell may protect you for a long time, 5 years, 10 years, even lifelong. Just like having vaccine as a young child, you're protected from mumps and rubella for the rest of your life. This can happen. That's why we are optimistic. Many patients may be cured with even advanced disease in the future. Okay, so I think there are no more questions. So, well, thank you everybody for joining me today. Hopefully I add to your knowledge in melanoma and education and the treatment options. Thank you.